Good morning, everybody, and welcome to our COVID-19 Town Hall. We're happy to be here today and thankful for those who have joined as we talk a little bit more today and have some experts with us to help address back to school. We're going to be focused today on K through 12, but a lot of the information is applicable if you have college students, but we'll also be following up with a town hall specifically for universities and college students within the next couple weeks. We are recording this, so I just wanted to make sure everybody's aware that this session will be recorded, and it will also be available and posted on our digital toolkit site as well. So if you could just advance to the next slide. Our presenters today, my name is Allison Hess. I'm the Vice President of Health Services. Been supporting the back to school efforts and the COVID vaccine strategies. We also have Dr. Allison Brzezinski, who's the Director of Infectious Disease. We have Roxana Larson, who will be talking to you today about sports and sports medicine, and then Dr. Swathi Gotham as well, who's a pediatric infection prevention specialist. So we're really excited to have this team here today. A lot of expertise available. They'll be available to answer questions. And we appreciate all the questions that were submitted in advance. We've actually built the responses into the presentation. So hopefully you'll have no problem getting those questions answered throughout the presentation. And then we'll also follow up and have some Q&A at the end as well if we didn't answer any questions, and we'll post all of the questions and the answers on the digital resource as well. So these are our topics today. We're really going to focus on the back to school resources that are available. We're going to talk a lot about mitigation, sports activities, vaccines, testing, and as I mentioned, we'll also be taking some questions and answers at the end. Next slide just talks a little bit about where our resources are located. So we do have a digital toolkit. We wanted to make sure everybody was aware that that was available. You can log into that site and it has a ton of information, has frequently asked questions. It links to local guidance and CDC guidance as well. Whenever we get questions from the team, when they come into any of our team members, we try and get those answered and post those questions and answers up on this site. So it's a great resource for information. We encourage you to utilize that resource. We're also going to be continuing with our webinars and town halls. We offer real-time support for questions. We have a multidisciplinary team at Geisinger that's made up of several key members across the organization to be able to get those questions answered for you. We're working with schools to review the back to school plans. And we also are providing vaccine information for parents and students. We have other materials available for the schools, printed materials, and digital resources as well. So lots of information that we're trying to put out there, but this is really your toolkit. It's for our communities, it's for our school districts. So every time we get requests or additions, we add it to this and have continued to make this a really dynamic resource for everybody. So with that, I'll turn it over to our next two presenters. Again, Dr. Allison Brzezinski and Roxana Larson are here with us today to talk to you a little bit more about mitigation. And at Geisinger, we know that this is a topic that people are really thinking about as they're gearing up for back to school. So excited to have them available to speak today. Thank you.
Okay, next slide, please. I think we're frozen, Allison and Betsy.
I have the next slide up, the CDC guidance for COVID.
Okay, my screen is frozen, but we'll keep moving along and hopefully it'll catch up. So welcome back. I think a lot of us know each other from last year's guidance, and I think it's hard to believe that we're starting back with another school year. But this school year, return looks a little different. If some of you can recall last year, I think there was still a lot of questions on whether or not schools were even going to open. This year we have a lot more confidence. I think information that we gained from the last school year. We know that students benefit from that in-person learning environment and that safe return to the in-person learning environment, that's key. And we're going to go through some of these strategies today to make sure that we can get your staff and your students back in that manner. A little bit of a difference from last year's guidance from the CDC to this year's is a shift from alternative learning models, depending upon cases in the community or cases in your school, to more of a layered protective strategy. So when you think of last year, a lot of the strategies that we presented to you talked about, should you do hybrid? Should you do virtual learning? Should you try to perform in person? That type of thinking or direction has really shifted. And now we realize that we can get these kids and staff back safely, but it's with a layered protective approach. And we'll kind of go through some of them. Something new in our tool belt this year that we did not have last year is obviously vaccinations. And we know that, widespread vaccination, this is a critical tool that we need to help really stop this pandemic. And we'll talk a little bit about how vaccination status, maybe among some of your staff or students, may also affect some of the decisions that you have in the event there is an exposure. And then really a back to the basics with some of the mitigation strategies that we know about, hand hygiene and personal responsibility when you're not feeling well, staying home, the physical distancing, and obviously the masking. And I apologize, Betsy, my screen has still not cut up. It's froze on the first one. So next slide.
Yep, got it.
Thank you. So COVID-19 vaccination amongst all eligible students and amongst your staff, your teachers, even household members, we know that's a really important strategy to help these schools get back. People who are vaccinated, we know, are at low risk for acquisition of the virus, and they're also at low risk for symptomatic disease or even, the severe disease. CDC does recommend vaccination for everyone who, sorry, I'm seeing some things pop up. I hope you guys are getting the slide. CDC does recommend vaccinations for anyone 12 years of age and older who are eligible. Currently in the United States, we do have 3 different types of vaccinations for COVID-19. We have Pfizer, which is a 2-dose. We have Moderna, which is a 2-dose series, and we have the Johnson & Johnson, which is a 1-dose. Currently, for those who are 12 to 17 years of age, that would include the Pfizer at the current time. So when looking at vaccination status, you'll hear in our presentation, we talk about those that are considered fully vaccinated. What do we mean by that? So anyone in your school district who had any of the 2-dose vaccines, which would be the Pfizer or Moderna, they're going to be considered fully vaccinated when it's 2 weeks after completion of that 2nd dose. If they did receive the 1-dose, the Johnson & Johnson, it's going to again be that 2-week mark. But again, that's a 1-dose series. So that's something important that again, understanding the nuances of what, fully vaccinated means when, again, you're investigating any type of a potential exposure or an outbreak. Again, it's good to kind of understand this terminology, because when and if you are faced with the decision of how to quarantine or potentially who should be tested or who should be worked up in exposure, that vaccination status again becomes an important clue. Keep in mind when you are working up an exposure, the one criteria that is not affected by vaccination status is going to be the close contact. And we'll get a little bit further into that. But again, I just want to make sure that we're all kind of speaking the same language when we're talking about vaccinations and vaccination statuses. Next slide, please. So updated on, I believe this was August 4th, the CDC changed the guidance when it came to mask wearing. So if a lot of you recall, pretty much during the summer months, there was a freebie, if you will, that if you were vaccinated, that we were not requiring masking indoors. And there was we reviewed a little differently those that were vaccinated versus those that were unvaccinated. So with the rising Delta variant, which again we'll get into a little bit later, And with the rising community cases, the CDC did just change their guidance again as of August 4th. And they now are recommending indoor masking for all. So that's both the unvaccinated as well as the vaccinated. Within the CDC school guidance, again, the recommendations are going to be anyone 2 years of age and older. This is students, staff, teachers, regardless of the vaccination status. We tend to get a lot of questions of, well, okay, we can kind of make sense of that, but what are we doing outdoors? Because the guidance is, it's a little vague, it becomes a little muddy. In general, outdoor transmission is going to be very low, not very likely. So, people don't, tend to need masks when they're outdoors, but, I would caution that with, if you're going to be in a crowded outdoor setting, if the kids are involved in activities where you're going to kind of have that sustained contact, that's when you really want to start, again, thinking about, they probably should be masked. And again, this is coming back to, we unfortunately have something new on the table this year, which is a highly infectious variant called the Delta variant. During school transportation, this is actually a CDC order, it's a federal order. This has been intact since the end of January, I think it was January 29th of 2021. So, anyone who is on transportation, this is public transportation, this also pertains to private schools, everyone on that transportation vehicle must be masked. So, when you look at guidance, sometimes there's differences in recommendations, there's differences in mandates. So the school transportation, we don't really have any wiggle room with that. That is a federal order. And I also just want to be reminding that, everyone, and just to be mindful that there are some students who may forget a mask. There are some that, perhaps, families are unable to afford them. So we do ask schools to please, again, just be mindful of those students. We really should have masks available for them. There's also an order in the COVID-19 school handbook that talks about there should not be disciplinary action taken on a student who doesn't have a mask, again, because it was something that they forgot or, again, that the family can't afford. So just, again, something to be mindful for. Next slide, please.
So as Dr. Brzezinski went over what we do with mask wearing when it looks at the general student population, same applies when we talk about sports. We are still following the CDC recommendations, which is for indoors. That would be including athletes, coaches, officials, and spectators do need to be masked as of the new CDC guidelines. Outdoors, the same principle follows here. If they're not able to withstand a 6 feet distance, it is recommended that they are in a mask, whether vaccinated or not. Those that are fully vaccinated may choose to wear a mask in a larger crowd, but the goal here is still to keep that social distance space. During school transportation, as with any school transportation, whether it is transportation for to and from school, transportation to and from a sporting activity or any type of club activity, if it is on a school bus transportation, they will need to be masked to align with the federal order. As of right now, we are still reviewing any new information that comes out, particularly related to sports, but right now we are aligning the sports activities will align with the CDC regulations. Next slide. So here are a few options when you're looking at face coverings and masks. There's some examples of what to choose when it's a mask. So you want to look at a mask that if it's a fabric mask, you have 2 or more layers of a washable, breathable fabric. You want to make sure it's completely covering nose and mouth. And I know that is a high topic of conversation when you're working with K through 12, especially the K through 6 and in the elementary level. It's that reminder to make sure it's covering both nose and mouth. Make sure it's fitting quite snugly around your cheeks. and around in this area. And also we want to make sure that there's, if possible, some type of wire loop that can be on top to pinch around the nose. The masks that we want to stay away from are those that make it hard to breathe, so very thick fabric masks. So you want it to make sure you're able to breathe through the mask. We want to make sure that there's not any type of valve on the outside of the mask, because that actually allows the airflow out instead of protecting the airflow. We also want to make sure that we're prioritizing the N95s and some of those KN95 respirator breathers just for the healthcare workers. For the school setting, fabric masks or even the level 1 masks are very appropriate. The key with masks is making sure it fits appropriately and fits snugly around the nose and mouth.
So physical distancing, there are going to be some changes to the guidance this year versus last year. Again, understanding that getting these kids back to that in-person learning is key. That we do ask all school districts, please implement that physical distancing to the extent that your infrastructure would allow. But with the caveat that, if you can't get that 6 feet, students should not be excluded from that in-person learning environment. So looking through, 6 feet versus 3 to 6 versus not able to achieve that 3 feet distancing, some things to keep in mind. In general, the CDC is still recommending people who are not fully vaccinated really should be the ones that we're trying to maintain that at least 6 feet of physical distancing. Interestingly, though, when we looked at some studies back from the 2020 to 2021 school year, we did see low transmission of COVID-19 in students who were in kind of that 3 to 6 foot range. But this was true for those that had that nice tight fitting mask in place. So again, going back to that layered approach, that we know the distancing is key. But if for some reason you're not able to really get to that 6 feet, then again, please, make sure that these kids are masked, because that's what's going to help really prevent that spread. Distance of 6 feet is still recommended between students and staff and teachers, and even teachers and staff in between themselves, particularly those that, again, are unvaccinated. So really kind of thinking about who are the players in that classroom, who is vaccinated, who is unvaccinated, and using that to really help build that layering strategy. Anytime that masks are going to be lowered or removed, such as in a cafeteria, obviously we have to feed our kids in school, really think about that distancing. And I think you guys did such a tremendous job last year with thinking outside the box and being creative on how to create these spaces. Anytime that you're going to have, large cohorting or activities that are going to be increasing ventilation, your chorus, your gym activities, again, thinking about other activities maintained in addition. If they commute. Thank you. In the 3 to 6 feet range, so again, there are a lot of school districts, just because of infrastructures, that it's hard to sometimes always achieve that 6 feet. And we have some good studies, and I think a lot of you even have some anecdotal evidence to show that it was, you were able to maintain those low rates when you weren't able to always achieve the 6 feet because your kids were masked. The CDC is saying, hey, we can certainly stack hands on this one and understand that 6 feet is hard. But again, these are the instances where they're really strongly saying, make sure that masking is in place. Keeping in mind where your community transmission is at the time, if when you're not able to achieve the 6 feet, and we'll go into a little bit of the differences in community transmission rates in the future during this presentation. But when you're in that low to moderate or substantial transmission range, again, they're saying, we think that transmission among kids who are 3 to 6 feet apart and masking is going to be low. There are some school districts out there, again, that were just not able to get to that even 3 to 6
foot range. And that's, again, where you really have to be mindful with layering all those approaches, the masking, the hand hygiene, the ventilation, really focusing on the personal responsibility, and someone that's not feeling well should be fully evaluated. And then again, the ongoing education to the staff about the importance of all the mitigation strategies. Next slide. So in the event that there is an exposure in your school district, we do something called contact tracing. And then based on the contact tracing, we guide the individuals, whether it's a student, staff, or teacher, to say, you know, we're either going to require, you know, the quarantine, or in the event you're positive, we're going to require isolation. So what is a close contact? The CDC has pretty basic definition that says, you know, anyone who was in 6 feet of a person who was diagnosed with COVID-19 for a total of 15 minutes or more over a 24-hour is going to fall into that period. Now, they did add an exception this year to their return to school handbook. And the exception is only for K-12 indoor classrooms. So this is not for the general public. And they say that in the classroom setting, if there was a child who was in that 3 to 6 feet of an infected student, and both of them had a tight, you know, nice fitting mask that they were consistently wearing, that they would fall into the exception of the close contact. So again, you know, kind of speaking to the CDC really trying to push this layering approach to decrease the risk amongst all the school districts. Keeping in mind that this only applies to K-12 for the students. This does not apply for teachers, staff, or other adults in the classroom setting. When you're looking at someone who does meet the definition of the close contact, again, this is where it's going to be important to understand what is their vaccination status, because there's going to be different guidance depending upon that. So if you have someone who is unvaccinated, they will be required to quarantine for 14 days. In addition to that quarantine, they're also going to be required or recommended to have COVID-19 testing within 2 to 5 days after that exposure. In the event that, you know, they test positive, then obviously there starts to be a contact tracing from that individual. In the event that they test negative, let's say on day 2, that doesn't remove them from isolation. But that testing guidance is something new that the CDC had just adopted. They also obviously recommend, which a lot of you had done last year, which is collaborate with your local Department of Health to help you walk through these contact tracings. Those staff or students that are fully vaccinated do not need to quarantine, assuming they have no symptoms and assuming that they do not have a positive test. So again, something new in terms of the guidance is that if you are fully vaccinated, considered a close contact, it is recommended that you do receive a test on day 2 to 5 after that exposure. You do not have to quarantine if you are fully vaccinated, assuming you have no symptoms. They also recommend, you know, anyone who was exposed, who is fully vaccinated, has no symptoms, negative test, you really, really, really have to be vigilant with that mask wearing. One exclusion to this, and this is where it can get a little tricky too, is that if somebody was previously diagnosed with COVID in the last 3 months, we do not recommend testing. And this is true for both the unvaccinated and the fully vaccinated. So no repeat testing within 90 days. And that just speaks to some of the limitations with a PCR that you can continue to shed dead viral particles that could inadvertently flag a positive test. Next slide. What's the difference between quarantine and isolation? A lot of times these terms are used interchangeably, but they really do mean 2 different things. The basic quarantine is someone who was exposed to the virus. Isolation is someone who actually has the virus and they're infected. So quarantine, again, you were exposed, we're kind of monitoring you for symptoms, you have to stay home for 14 days. You can remove from quarantine in the event that you don't develop any symptoms, you don't develop a positive test. And again, it's that 14-day. Isolation, again, is when you actually have the virus and you're infected. And isolation is typically the 10-day period. And they can safely be removed from isolation, assuming no symptom development, improvement in symptoms and no fever within 24 hours. Something that we get asked a lot about is we have something called a COVID long hauler, where you have these continual symptoms. Something very common that we're now seeing is individuals who lose that taste and lose that smell, and several weeks or even months later, that's still occurring. And some school districts have reached out and said, can they safely return because they still have this ongoing symptom? Unfortunately, that is something that we're continuing to see. That would not exclude them from coming back after that 10-day mark, the ongoing loss of taste and loss of smell. Unfortunately, it's just something that we're seeing in a lot of individuals after contraction of COVID-19. Next slide. When we're looking at the surrounding community that we live in, we do a lot of different monitoring to determine how much virus is circulating. And a lot of you will hear about different categories of transmission, the low, the moderate, the substantial, and the high. And that's really based on objective information. So it's looking at how many new cases occurred over the previous week per 1,000 people in that population. And again, I think it's a really nice objective number that really helps look at what's the risk for your population. They also take into account the percent positivity of any new COVID-19 tests. So out of the 60-some counties in Pennsylvania, I mean, we're in the last I look, I think there's 54 or so that unfortunately have moved up to that substantial or high range. A lot of the school districts that we're speaking with today, you're in that substantial and high range. So again, that's important when you're reading through any of the CDC guidance on this, and they start talking about what does your community transmission look like. This is kind of the table that they're using to determine, are you substantial or high? So good to keep an eye on that. It's unfortunate at this point, it's kind of easy for us to say, the majority of us are in that substantial and high range. Next slide. I think that one of the last points I wanted to talk about is something called this Delta variant, and just so that we all have a basic understanding of when we hear about it and what does it mean. So the WHO, which is the World Health Organization, it's kind of like the CDC of the world, if you will. They came out with a nomenclature system several weeks or months ago that wanted to focus on the Greek alphabet of naming new variants, similar to, think of storms that are occurring. And the Meteorology Society says, well, we're going to use, names. The WHO said, we're going to use the Greek alphabet. And it makes it a little easier for the community to understand, is there a new variant that's circulating? But it also makes it easier than perhaps understanding, are we at the B117 or the B351? So the Delta variant is the most commonly circulating variant that we have in the United States at this time. It's considered something that we call a variant of concern. And a variant of concern is something that we know is increased transmissibility versus the original type that came out of Wuhan. We know that it could be leading to increased cases. And that's a little different than something called a variant of interest. For example, the Lambda that a lot of people are talking about from the media. The Lambda variant is a variant of interest. And that means that it's circulating. We're aware of it, but it doesn't seem to be that much more transmissible. So it's, I think, important, one, to understand that not all variants are created equal. There's different types. And that why are we talking about Delta so much? So Delta, we know, produces about 1,000 times more viral load, so more viral particles. It makes it easier to transmit to someone who's susceptible versus, again, the original strain. This is particularly important when we're talking about those that are unvaccinated or the children that perhaps are not eligible yet. So again, important to understand when we're talking about Delta, some of the common risk mitigation strategies that we talked about last year become even more important because again, it's just a much more powerful strain than the original strain that came out of Wuhan. The vaccine is still doing what it's supposed to do, and this is also true for the Delta strain. Or for the Delta variant. So at Geisinger, we vaccinated over 160,000 individuals. And of those, only 14 had required hospitalization. Pretty stark number. So that's less than 0.01% of those that we fully vaccinated required hospitalization for COVID. And even more important, of those who come into our hospital, they were all discharged. So 0 required ventilation support and 0 died of COVID of those that were vaccinated. So again, the vaccine is still doing what it's supposed to.
So as we move into thinking about as our children are coming back to school, as we're coming back to sports, as for many of our schools, you know, part of your preseason started today, fall football athletes returned. Things to remember that we spoke about last year are still very key today, which is hygiene and hydration. So looking at it from the standpoint of, instead of having the huge water jugs with shared water bottles that we've had in the past, we still need to stay focused on student athletes bringing their own individualized water bottles, bringing their own water jug from home, a water bottle. Schools still provide the large water coolers to refill, but also please ensure and remember, keep the hand sanitizer right there so it can be used pre and post. For the sports venues and for even the band, there are we've worked with a few of the schools when it comes to their woodshop program, and there's some great resources out there where you can build foot pedals that will actually allow you just to step and it triggers the nozzle, and then they can refill without even hand touching the actual cooler. But keeping hand sanitizer right there by the cooler just to help enforce that is still very much a key to hygiene and hydration. Locker rooms, I still want to encourage, we're really social distancing in locker rooms. You know, when at all possible, all post-workout showers should be done at home. Let the athletes shower at home. Keep the locker rooms for bathroom use only. Try to I think we used to limit just to one, but I think we can increase a little, but still you don't want to overcrowded locker rooms. You need to utilize that and view that as an indoor space with the proper cleaning is periodically throughout this time frame of whether it's a practice throughout the school day. That is all still very, very important and very key to some of the efforts that we started last fall. Next slide. Then looking at the equipment room, those are the equipment in the weight room, as well as any equipment you have in other shared spaces in the building. When you think of any wood shops that are in your buildings, any different type of hands-on lab spaces that you have in a building. Still, we want to encourage non-vaccinated student athletes should still wear a face mask during weight room activity because they are inside. It's very important to continue using the pattern that we set last fall, where spotters should be on either side of a bench instead of right on top of the athlete. Put 2 spotters per person so that they're on either side of the weight. Also, very, very key is ensuring that all equipment is wiped down between every use and you allow it to thoroughly dry. So a lot of our schools have resources and they can reach out to us for areas and recommendations on where to order, but it is very important that there is cleaning equipment and cleaning supplies in the weight rooms and in any space that's going to have some shared use of equipment. And that equipment is wiped down, dry, and allowed to dry before it's used again. So our key takeaways from this, you know, our students really benefit from in-person learning. As Dr. Brendos just said, the safe returning to in-person instruction is very much a priority. The vaccination is the leading public health prevention strategy to end the COVID-19 pandemic. We want to promote vaccinations. Due to some of the circulating and highly contagious Delta variant that we discussed, universal indoor masking is very highly recommended, especially inside. And in addition to the universal indoor masking, we want to make sure that there's the 3 feet of physical distance between the students within the classrooms. We also want to, there's options for screening, testing, ventilation, hand washing, respiratory etiquette, all those things that we spoke about last year and you implemented already just to continue the mitigation. Those are very good protocols to keep in place. We want students and teachers and staff to stay home when they're sick, and to reach out to their healthcare provider. Those that are serving children under 12 that aren't eligible for the vaccine, please continue to implement layered protection. We want the masking, we want the hand sanitizers, we want to make sure, we want the kids in person, but we want them safe and in person at the same time. A few questions that did populate ahead of time that I wanted to address that were really low focus just around sports. So there was a few questions that we received about sports and the vaccines. Right now, we have not been given any guidance by the PIAA or by the CDC or Department of Health that there needs to be a proof of vaccination. So any of the plans that would come with sports are going to align with your return to learn policies that your school set out. We do still encourage the masking of the unvaccinated, but right now there's not a requirement to show proof of any type of vaccination for athletics. Any type of spike that would occur, so the continuation of sports activities are going to fall in line with what goes on with the school when they're in the community, when you're looking at the community's level, whether it is substantial, whether it is high. Right now, sports will still align with whatever the school return to school plan is and whatever level they're falling into. For masking with sports particularly, we're still aligning with all CDC and all the recommendations to decrease further spread. Non-vaccinated coaches, parents, student athletes will be recommended to be masked, even in the bleachers when they're not able to maintain that 6 feet of social distancing.
Thank you. Perfect. Hi, I'm Swati Gautam. I'm going to be spending the next 10 minutes talking about pediatric COVID and vaccinations in the pediatric population. I'm a pediatric infectious disease specialist and the director of infection prevention at Janet Wise Children's Hospital here in Denver. Next slide. So the epidemiology. So essentially for pediatric COVID, people have been kind of downplaying it. It's true that COVID has really affected the elderly and the adult population, but pediatric patients do get COVID and they do get ill with COVID. The number and rates of cases in children have been increasing. So in the beginning of the pandemic, pediatric population less than 17 have been only about 2% of all COVID cases. And as more and more adult populations get vaccinated, the disease is mainly in the unvaccinated. So children are part of that unvaccinated group. So the rates of COVID are now rising in children, where they currently represent about 20% of all COVID cases nationally. The true incidence of COVID in children is not really known. And that is because mostly in the beginning of the illness, in the beginning of the pandemic, we were actually getting all the tests for those that are really hospitalized in the hospitals, those adult elderly. So children that had milder symptoms were not being tested. So we don't really know how many children COVID has affected since the beginning of the pandemic. Initially, children were thought not to get COVID, and that's the wrong thought, that children could not get infected. And pediatric infectious disease doctors didn't really believe much in that because children get other respiratory viruses as well and have milder infections. But recent data has shown that kids are as capable of getting COVID as adults are, and they secrete similar amounts of virus, and therefore they're as infective, and they have the same ability to infect others as adults do. So the only difference is in the severity of the disease sometimes, but they're still capable of getting COVID and passing it on to others. So as I said, even though kids get less severe disease, there are children that have been hospitalized with COVID. And 1 in 3 children that have been hospitalized due to COVID were admitted to the ICU with severe disease. And there have been, since the beginning of the pandemic, there's been about 18,000 admissions in children. And you'll see with the Delta variant kind of raging across the south of the country, there are many children's hospitals in the south that are currently being overwhelmed with admissions. And then there's an entity known as MISC, which is multi-system inflammatory syndrome in children. That is a post-infectious phenomenon that I don't really have time to get into, but that's a cause of having the COVID disease in some children that causes significant amount of inflammation across the body, particularly affecting the heart. And these are healthy children. And due to COVID, there have also been deaths that have been reported. So there's been at least around 300 deaths in the United States at the beginning of the pandemic. And this is not a small number, considering that these are healthy children that otherwise should not die of just a viral illness. And even children who get milder infections seem to be getting these post-COVID conditions or the long hauler COVID where they're fatigued, have headaches, and chronic symptoms for a prolonged period of time. And we really don't know what the virus does long-term to the bodies of these kids. So that still needs to be studied particularly. Next slide. So this X-ray I just want to show you is of a 15-year-old that had COVID. So white in the lungs is a bad thing. Lungs are supposed to be filled with air and black. So this X-ray, Dr. Brzezinski, who does adult infectious disease, can attest to, looks like any other 60-year-old with COVID. So children can definitely get severe COVID illness. Next slide. So what we know of those that get admitted into the hospital that get MISC conditions, that get severe disease, are in the tip of the iceberg. As I said, children with that are minimally symptomatic or have no symptoms with COVID illness are at the base of the iceberg. That is a much more broader population. And these kids may then tend to have long haulers disease and other things that just had mild flu-like illness. They can have certain long-term effects. We just don't know what they are. And this base of the iceberg will then spread the disease to other unvaccinated and vulnerable groups. Next slide. So vaccinations, so vaccinations, the only current vaccine that has been approved under the emergency use authorization for pediatric patients is the Pfizer vaccine. It is recommended for 12 and older. And they can, in the beginning, we were not trying to do it along with other vaccines. We wanted like a 14-day gap. And that was because as things were, as this vaccine was new, we're just trying to make sure that there were no side effects that could be attributed to this vaccine. And now that we've been doing this for several months, the CDC had removed that requirement of not getting other vaccines within that 14-day gap of the COVID vaccine. And that's because we're very confident about the safety data that has come out. So you can get it with other childhood vaccines that are required so that you don't have to keep going back and forth. And so the current clinical trial data is also on 6 to 12-year-olds, and that data is pending with the Pfizer vaccine. The Pfizer press release says that they're going to be submitting that data in fall, September 2021, for FDA for their approval. So vaccinating the 6-year-old school age group under the age of 12 is not going to be feasible before school starts. And it's probably going to take us several months to kind of vaccinate that population so that there's herd immunity within that school age group. So there's going to be several months prior to the fully vaccinating that 6 to 12-year group. The other thing that I want to comment on the vaccine is the vaccines for pediatric patients is very, very safe. From the data that we've looked at from 12 and older, there's very minimal side effects. There's an exceedingly rare side effect called myocarditis, which is, I'm sure you guys have heard about. This is, again, inflammation of the heart that is happening in some adolescents, very rare, a few cases in a million doses. And this is through the VAERS program. So this is vaccine adverse effect reporting surveillance. And this system picks up any little adverse side effects. So you have to vaccinate 1 million people to figure out 1 in a million side effect that occurs very rarely. So this gives us confidence in the system itself that monitors the side effects from the vaccine. So myocarditis that happens due to the vaccine is exceedingly rare, and it's very minimal. Some of these adolescents have just minimal chest pain, some shortness of breath. Generally, it seems to happen after the second dose, a few days after the second dose of the vaccine. And it can be treated conservatively. People give NSAIDs. Some children we had about 2 kids that needed to be admitted, but none of them needed ICU care, and they were managed conservatively and then sent home. So exceedingly rare side effect. Remember that the virus itself also gives you heart inflammation. So the COVID virus, there's studies on athletes, about 2% of athletes, that were had an MRI of the heart showed signs of inflammation after they got COVID illness. So that's a significantly higher risk. And then there's that MISC, the multi-system inflammatory syndrome in children. That also has significant heart inflammation. This is where children, and we've treated 40 of those kids, 50 of those kids at Geisinger, and a lot of them had needed ICU level care, and a lot of them were very, very ill. So on the whole, I just wanted to say that the vaccine is much, if I could add more muches, I will put that in there, safer than the virus itself. And the VAERS type of surveillance and the multi-level surveillance systems that we have looking at adverse effects due to the vaccine makes us even more confident in the current data that we have. So I would encourage all children that are eligible to get their COVID vaccine. Next slide. Okay, so this is from the AAP, CDC, and Pediatric Infectious Disease Society recommendations for safe schools. I know Dr. Brzezinski and Roxana have already talked, but the main recommendation is that this is a species model where you have multiple layers. So the main thing is the goal is to keep children in school for in-person learning as much as possible. So the initial CDC guidance, I know there's a lot of confusion about masking. The initial CDC guidance when they removed masking was only for vaccinated people. They said only unvaccinated people should continue to mask. That guidance has never changed. With the removal of masking for vaccinated people, some state governments have removed mandated masking across the board because it's kind of hard to police who's vaccinated and who's not. There was no comment on what schools should be doing by the CDC. Then the AAP had come out with their recommendations to recommend masking inside schools, inside buses, regardless of vaccination status. And that is because we know that majority of children, under the age of 12, first of all, under the age of 12 are not eligible for vaccination. And the majority of children over the age of 12, only 20 to 30% of those children are vaccinated across the country, depending on which state you lived in. So the majority of adolescents are not vaccinated as well. And then within staff, there are some that are going to be vaccinated and not going to be vaccinated. So the AAP approach of, masking inside schools and regardless of vaccination status was just more practical and easy to enforce. And for children, it was more consistent. So that had come out. Unfortunately, the CDC at that time was a little behind, and the schools had to put in their summary recommendations prior to the CDC guidance. So I do sympathize with the schools. And then the CDC and Pediatric Infectious Disease Society had recommended the AAP's guidance. And the key, again, is vaccination, masking, distancing, as Dr. Brzezinski has talked about, where particularly masking is not feasible, like in lunchrooms, et cetera. And then rapidly identifying and separating those with infection, as Dr. Brzezinski had talked about with contact tracing, et cetera. Next slide. So again, the goal is to keep as many children physically present for in-person learning as much as possible. So the summary points are: the current vaccinations protect against death and hospitalizations against COVID disease. So besides everything that we were doing last year, and schools did an amazing job, as Dr. Brzezinski had said, and as Allison Hess had said, about keeping schools free of outbreaks. We really did not have many outbreaks locally in our schools. But now we have vaccination to add to that layer of protection. So encouraging vaccination is actually very, very important. This is a race to vaccinate against a mutating virus. So as infectious disease doctors, Dr. Brzezinski and I are not surprised that the variant that is taking over is the one that spreads more. So that's not surprising at all. There'll be multiple other Greek alphabets that will come along, if we don't stop transmission. So the only way to stop mutation is to stop transmission. So vaccination, and those who cannot vaccinate or have not vaccinated, masking And masking in general within schools to make things, enforcing all those things is going to be important. So the same strategies that we have been advocating all along, none of that has changed since April. Masking, distancing, hand hygiene, whatever you can do to prevent the circulating strains from transmission is going to be important. We as pediatric experts are actually worried that schools will become a nidus for infection spread, and there may have to be shutdowns. So even though nobody's mandating anything, the government is not mandating masking, if there's outbreaks in schools, the health department can come and shut that down, and then no one is in person for their in-person learning. So, careful attention to these plans is going to be important in stopping the spreads. We've done it before in the past, and I'm confident that we can do it again. Thank you.
Thank you so much, Swati. Really great information, and thanks to Roxana and Allison Brzezinski as well. Just to kind of wrap this up, because we do want to allow some time for question. I just want to note, if you do have questions, if you want to start putting them in the chat, we've been trying to answer them throughout kind of the broadcast here, but please add those in and we'll try and get to those at the end. If you are interested in getting information, again, we're creating some flyers with information about the importance of vaccine that will be available in the digital toolkit, but we are offering at these 4 locations, our community-based clinics, but additionally, we've just stood up the opportunity to get vaccinated at 8 of our retail pharmacy locations, which are listed there in Lewistown, Pottsville, Grays Woods, which is out in State College, Woodbine, Lock Haven, Mount Pleasant, Mount Pocono, and Dallas. So some other options there, and there's just a number where you can call or a website you can visit if you're still looking for a vaccine. And we do have Pfizer at Geisinger, so we are able to do those pediatric 12 to 17-year-old patients. And then the next slide, just again about testing, I wanted to make sure we took the opportunity to let you all know that obviously during the pandemic, we had testing sites that were up across the coverage area. There have been decreased volumes in the testing from what we were seeing historically. And so we've consolidated the testing options. So a lot of times people will ask, maybe students will ask or parents will try and determine where to get tested. If you have symptoms and you have a Geisinger primary care, you're ill, you really need to see your doctor, then you can schedule an appointment with your PCP. They can test you while you're there as part of that process. If you don't have a Geisinger PCP and need tested, or you're mildly symptomatic and maybe don't think you need sick care, you can get tested at our convenient care sites. We are also doing vacation testing there. That is not covered by insurance, but it is available at that facility. And then also if college students need that return to school testing, that's available at those convenient care sites as well. And you can utilize that by scheduling at any convenient care location, or you can simply walk in to get that test done. So we want to just make sure you had that information. So with that being said, want to make sure that we get to some of these questions. And so I'll start to read a couple of these off. Anything that we don't get to, we'll also post all of the questions and the answers on the digital toolkit, so you'll have access to those in advance. So it looks like there's a lot of questions about masking. And so Allison Brzezinski or Swati, if one of you want to just kind of generally hit some of those responses, that would be great.
So I can take the risk of masking to children. So kids have actually done a great job, surprisingly so. Elementary school kids, preschool kids have done a great job masking all day and every day, and there's no risks to doing that. They did that last year, and surprisingly, they've been pretty compliant with it. There could be peer pressure of other children masking, and there's probably good role modeling going on by teachers and enforcing of that. So there's no risk of masking every day. And Alton, I think, has addressed some of the messaging that should be done for children. My masking protects you, your masking protects me. So what the mask does is that it keeps the secretions to your face so that there's not multiple secretions with respiratory droplets with virus that are kind of circulating around. So the best way the mask works is if everybody else around you is also wearing it. There's some filtration component to it, but it is mainly for preventing your respiratory droplets, potentially that are infectious, lingering in the air. Anything else you want to add to that, Allison?
No, again, I think, again, the two big things you want to think about, because I struggled with this as a mom with kids going back to school, was, oh my gosh, like, how am I going to find something they're comfortable with and the fit? I allowed them to pick out fun patterns. So, my little guy, he's into Super Mario Brothers, and he was like, Mom, this is a cool mask. And my daughter was into puppies. And so getting them sometimes even engaged in, hey, do you want to pick out something cool that you can wear? Interestingly, may help with that, defiance that they may have with putting one on. Finding, again, to me, it was a soft material that they're going to keep on. So, I wasn't going gung ho with, I need this really thick layered mask. It was something I knew that they were going to be comfortable, keep on. I like the ones with the adjustable ear loops because it allows for a little bit of a better protection. And, interestingly, they did better than I did. To be honest, I put it in the chat, but my daughter sometimes would be driving her home and I'm like, Emma, you can take your mask off. She forgot that she even had it on. So those of you that maybe are a little on the edge with your kids that maybe just starting to school this year, I was there. I understand, the concerns that my kids is going to leave this on, but have faith in them. Like I said, they I think reacted better than I did to some of these.
Great, thank you. And there's also a question about vaccines. Somebody asked if we have J&J here at Geisinger. Right now, we have a very small amount of J&J. We're using that primarily for inpatient. In our community clinics, our retail pharmacies, we are using Pfizer. So if you look on the Department of Health website, though, you can see where different vaccines are being offered, and you can contact those areas if there is a specific vaccine that you're looking for. But currently, we just have a very limited amount of J&J, and it is being used for inpatient. For Swathi, there was a question about, is there any indication of when vaccine will be available for the under 12, and also how long is it effective? I don't know if you can take that one.
Sure. So under 12, I know the studies have been done 6 to 12. The data is out there. The FDA is looking for 4 months worth of safety data instead of 2, which is fine. So they're anticipating around September-ish. They're going to submit. Pfizer is going to submit for EUA, so they'll submit all their data. At that time, we as infectious disease doctors can also see that data, and multiple other societies like the ACIP, the Pediatric Infectious Disease Society, et cetera, they'll be seeing that data. Because the dosing is different, so you don't give the same dose to a 6-year-old that you would for an 18-year-old, essentially. So that's going to be key, but it's going to be taking a while. So the FDA has to look at it in September and then approve it. And it's going to take, as I said, months to kind of get all the school-age children vaccinated. So we're going to be going a while before we get herd immunity in that population. And so again, masking is going to play a key role in terms of our mitigation effects in that population. And then the other question is, how long does the protection last? We are not sure. There seems to be some preliminary data in terms of, whether or not your memory part of the immune system gets affected. So the CDC is currently looking at that, whether or not we need booster vaccines, et cetera. So that we will not know for, healthcare workers will be vaccinated for about a year now, starting December, January. And that population will be important to see whether or not there's any breakthrough cases there in order for us to know how long the protection lasts. But like the preliminary data, given which parts of the immune system gets activated, your long-term immune system seems to get activated with this. That's going to be key. And God forbid if there's any vaccine escape variants, so there's strains that, where the vaccine doesn't work for, knock on wood, all this current variants of concern the vaccine does work for, as Dr. Brzezinski had said, including the Delta variant. So we're kind of hopeful that we vaccinate enough people in a timely manner so that we can stop the transmission, so that we don't get a variant where the vaccine doesn't work. So on the whole, we don't clearly know, but we remain hopeful, and there'll be more data to come.
Yeah, absolutely. Thank you. And I think just one last comment, and then we'll wrap here. There was a question about whether or not precautions are taken when patients present to their PCP. Absolutely. We're still very cautious as people come in. We're still screening patients as they come in for symptoms. Again, requiring masking right now currently at all Geisinger facilities. So we will be taking those precautions similar to what we've done over the course of the last year. So on that note, I see a lot of questions that are kind of still trickling in here. What we'll do again, we'll take all the questions that we had. We hope that we were able to provide you with some additional information today. We'll get those posted on the digital toolkit. And again, this is also recorded for reference, so you can circle back and listen to it as well, or we can also get it distributed out to others who may have had some difficulty joining. Again, really appreciate your time and attention today. Hope this information was helpful. And we're with you. We're here with you as you enter this school year. We recognize that it has some potential challenges ahead for everybody, but we want to walk this journey with you, and we're happy to be your healthcare partner. So hope everybody has a great rest of your day, and thanks again for joining.